the fourth General Club, a joint effort by ACE, ISAR, and IFS with a knowledge partner as CooperSurgical. Today, we are joined by Dr. Varsha Samson Roy, who is the consultant embryologist and scientific director at Manipal Fertility, Bangalore. She will be the speaker for today's General Club. The topic is Day 5 versus Day 6 Blastocyst transfers, a systematic review and meta-analysis of clinical outcomes. This is a Human Reproduction Journal, volume 34. It was published on 23rd October 2019. The moderator for today's session is Dr. Gaurav Majumdar, who is the Chief Clinical Embryologist in IVF Sir Gangaram Hospital, New Delhi. So now I would be transferring control to Dr. Varsha, and she will carry it from now on.
So good evening, everyone. At the outset, I would like to thank ACE, ISAR, and IFS for this wonderful academic journal club, and of course, the knowledge partners, CooperSurgical. So we do know that the last decade has seen a significant change in our embryo transfer policies, with blastocyst transfer taking a preference over cleavage stage transfer for reasons very well known to most of us. Blastocyst transfer does positively impact the implantation potential, though studies also suggest that the cumulative pregnancy rate between blastocyst and cleavage stage transfer may not be significantly different. However, there's no doubt that blastocyst transfer has significantly contributed towards reducing the multiple pregnancy rate. In India too, we do see an increasing trend towards clinics preferring a blastocyst transfer, whether fresh or frozen, rather than cleavage transfer. Now, in the absence of a time lapse, how does the IVF lab or the embryology lab go about in blastocyst transfers? So approximately around the same time daily, the lab monitors the embryos, in this case, day 5 embryos, grades them. Then in consultation with the clinical team, we decide on whether we want to transfer them, whether we want to freeze them, or we want to go ahead with an extended transfer of another day or so. So basically, our blastocyst transfer policies depend majorly on the quality of the blastocyst. So is the developmental rate here not significant? Does it not contribute towards the outcomes? So this is something we wanted to understand, and hence we chose this meta-analysis, day 5 versus day 6 blastocyst transfer, a systemic review and meta-analysis of clinical outcomes by the French group led by Michel Bourdon. So when we proceed with blastocyst transfers or freezings, there are a few questions which commonly come to our mind. The first question being, which is the optimal day for transfer? Is it day 5 or day 6? And in some scenarios, can day 7 also be considered? Does the outcome differ between fresh and frozen cycles? And why are we so concerned about delayed blastulation or delayed developmental rate in embryos? So now, if we look at the materials and methods in this study, a digital search was done between 2005 and 2018 on PubMed, Embase, and Cochrane Central Register of Controlled Trials and the Cochrane Database of Systemic Reviews. And all the full text published articles within this duration were identified. All of these either looked at day 5 or day 6 or combined transfer. They were either fresh or frozen or both combined transfers. The outcomes this meta-analysis looks at is the primary outcome of a clinical pregnancy rate, and the secondary outcomes studied here are the implantation rate, ongoing pregnancy rate, live birth rate, and miscarriage rate. Now, all the articles that qualified for this meta-analysis had to report on at least one of these outcomes mentioned here. The conduct and reporting of this review was guided by the preferred reporting items for systemic review and meta-analysis, which is also called PRISMA. And this is their flow diagram. Out of the 894 articles that were identified in the digital search after screening and after they having gone through the eligibility criteria, we can see that 29 were included in the final analysis. So the data analysis was done by Software Review Manager 5.3.5, and a random effect model was used. A statistical significance was achieved when p-value was less than 0.05. Since it's a meta-analysis of multiple studies, a statistical heterogeneity is bound to be there and was calculated by chi-square. A funnel plot was also done to know if there was any bias in the publication, and then it was classified as low, high, and unclear risk. Day 5 transfer was taken as the reference group, and these groups were again analyzed into subgroups of fresh and frozen transfer, and the frozen transfer again was subclassified into those embryos which were frozen by vitrification and those by slow freezing. Coming to the results, the primary outcome analyzed was clinical pregnancy rate. For this, 23 of these studies qualified, which reported on the clinical pregnancy rate. These included a total of 12,837 embryo transfers. As you can see, majority of these are day 5, almost 63% of these transfers are day 5 transfers, and around 4,700 are day 6 transfers. Of these 23 studies that were studied for clinical, for the primary outcome of clinical pregnancy rate, fresh transfers were only 2, 20 were frozen embryo transfers, and 3 were combined. Among the frozen embryo transfers, vitrification included 12 studies, and there were only 6 studies in the slow freeze group, and another 3 which combined both vitrification and slow freezing. Now, when we come to the overall clinical pregnancy rate, which means overall of both fresh and frozen, as you can see in the forest plot, there was a significantly higher clinical pregnancy rate for day 5 embryo transfers as compared to day 6 embryo transfers. Now, when this data was subclassified according to the subgroups of fresh versus frozen, and again in the frozen group, whether they were frozen by the process of vitrification or slow freezing, the conclusions remained the same, stating that day 5 transfers had a higher clinical pregnancy rate as compared to day 6 transfers. Meta-regression adjustment was done for 2 factors, mainly the age of the patient and the mean number of blastocysts transferred. Though they showed a high residual heterogeneity, they did not affect the final outcome. Coming to the secondary outcomes, first of the secondary outcome study was the implantation rate, and there were 17 of these studies which reported on implantation rate. The overall implantation rate, which involved both fresh and fed transfers, again day 5 was significantly higher as compared to day 6. Similar was the conclusion for fresh transfers and frozen transfers, where vitrification was the method for cryopreservation. However, when the analysis for slow freezing was done, there was no significant difference between day 5 and day 6 implantation rates, but however, a trend in favor of day 5 was observed. Coming to the next secondary outcome, the ongoing pregnancy rate, again 13 studies qualified for this analysis, and overall including fresh and frozen transfer with vitrification, day 5 definitely showed a higher ongoing pregnancy rate as compared to day 6. As far as frozen embryo transfers by slow freezing method were concerned, there was no significant difference whether the transfer was done on day 5 or day 6. Coming to the most important parameter, the live birth rate. The live birth rate again was significantly higher overall for fresh transfers and for vitrification frozen transfers for day 5 as compared to day 6. Again, in the slow freezing group, there was no significant difference in the live birth rate when compared with day 5 as compared to day 6 transfers. The miscarriage rate, and this is also one of the important outcomes. the overall miscarriage rate and the miscarriage rate for fresh transfer and vitrification frozen transfer was significantly higher for embryos which were frozen or transferred on day 6 as compared to day 5. In the slow freeze group, again, there was no significant difference. Now, a sensitivity analysis was again done on all these outcomes, the clinical pregnancy rate, implantation rate, ongoing pregnancy rate, live birth rate, and the miscarriage rate. Now using even a fixed effect model, which did not modify the results that we have discussed. However, a sensitivity analysis was again done, since we do understand this is a meta-analysis involving multiple studies. So the embryo, when a sensitive analysis on the embryo quality, the oocyte source, whether it is a donor or autologous, or when a pre-implantation genetic testing was done on these embryos and then followed by a transfer, when a sensitive analysis was done on these 3 parameters. As far as the embryo quality was concerned, the overall analysis, significantly higher clinical and ongoing pregnancy rates were seen for day 5 transfers, irrespective of the embryo quality as compared to day 6. The oocyte source, only one study stated the source of oocyte, which was donor oocyte, which obviously showed a significantly higher clinical and live birth rate with day 5. However, no significant difference in the miscarriage rate was seen, whether a donor or autologous oocyte source was used as compared to day 6. Regarding the euploid transfer, there were only 2 studies included here. They were fresh or FET, and one of the study had combined, and it did not show any difference in the clinical pregnancy rate, ongoing pregnancy rate, or live birth rate when euploid transfers, whether they were biopsied on day 5 or day 6, were considered. The limitations of these studies are, however, that these are observational studies. Multiple studies have studying different parameters and having different criteria of selecting of patients. Obviously, there is clinical heterogeneity of the studies. Some studies did not adjust for confounders, and presence of bias in this, in spite of the best efforts, cannot be excluded completely. The slow freeze group was a very small group here, and very few studies were included here. We do understand in this kind of a study, it is very difficult to design an RCT which compares patients receiving transfer both on day 5 and on day 6 and having to conclude on their clinical outcomes unless these are frozen embryo transfers. So now we move ahead with the discussion. To the best of my knowledge, this is the first review which addresses both the fresh and the frozen outcomes in blastocyst transfer. Even in the frozen embryo transfer group, it addresses both the vitrification and the slow freeze method. The outcomes concluded here are that day 5 has a better clinical outcome as clinical pregnancy rate, ongoing pregnancy rate, and live birth rate is concerned. The miscarriage rate is significantly higher for day 6 embryos as compared to day 5 embryos, and this is both for fresh and frozen transfers for embryos which were vitrified. So when both day 5 and day 6 embryos are available, due consideration should be given to day 5 embryos. Day 6 embryos should be considered probably only in the absence of day 5 embryos. Now, there are other studies whose findings are in accordance with the results and with the study that we have, with the meta-analysis that we have discussed here. However, I would like to bring into discussion this study, this meta-analysis by Shesh Kamal Sunkara in 2010. This was the biggest study, biggest meta-analysis which looked at frozen embryo transfers and their outcomes. Total number of studies included here were 15. Majority of them, as you can see, were with slow freezing method. Only 2 included vitrification method. And this study obviously only has captured the frozen embryo transfers. Now, what were the main findings of this studies? There was no significant difference in the post-thaw survival if we compare day 5 and day 6 embryos. The clinical pregnancy rate, ongoing pregnancy rate, and the live birth rate was significantly higher with day 5 as compared to day 6 embryos, which is in concordance with the earlier meta-analysis that we've been going through. If the embryos had the same morphological quality at the time of freezing, then Shesh Kamal Sunkara's meta-analysis states that there is no difference in the clinical, ongoing, or live birth rate, whether you froze embryos on day 5 or day 6, if morphologically they were graded the same. This is slightly contrary to what the meta-analysis that we are going through concludes, which again, Gardner's classification is most commonly followed, where our study suggests that the outcomes are different, are better with day 5 as compared to day 6 embryos in the vitrification group, even if they were of the same morphological grade. So conclusions in both these studies regarding slow freezing group more or less are similar. However, we need to understand that though this is a huge study which has looked at 2,500 frozen embryo blastocyst transfers, it does lack the power concerning the vitrification group. This was a study which looked at publications between 1980 and 2010. So we can very well imagine that this was the time all of us were moving from slow freezing to vitrification. There is a learning curve for vitrification, and hence bias due to learning curve cannot be eliminated in this meta-analysis. And they hypothesized that in fresh cycles, the endometrial, embryo endometrial synchrony could be more important than the rate of development in fresh transfers. So how is it different in fresh transfers compared to the frozen transfers? So we do know that there is an implantation window. This is the time period during the cycle when the endometrium is most receptive of the embryo that enters the uterus. This extends to a duration of 4 to 5 days in a natural cycle. If it's on an average a 28-day cycle, in a natural cycle, the implantation window is around between day 20 and day 24. However, in stimulated cycles, it is known that this window is advanced by a day or 2. So there is premature ripening of the endometrium in stimulated cycles, and this is known to affect the implantation of especially developmentally advanced embryos or blastocysts. Now, if the blastulation rate or if the blastulation development delays further, then we are looking at this window shutting down. And hence, freeze-thaw cycles, specifically in these kind of delayed blastulation embryos, could act as a rescue because of the closure of the implantation window. So now that was about day 5 and day 6 embryos, the developmental rate and how it could implant. But today, with a lot of emphasis on PGT-A and PGT-M and analyzing these embryos prior to transfer, how are the outcomes different for day 5 versus day 6 transfers? And how is the ploidy status of the delayed blastulation? Does it affect the ploidy status as well? So studies do suggest that day 5 blastocysts do have a higher implantation rate, and the aneuploidy rate is definitely higher for day 6 embryos. But there are studies which suggest that if you have identified the ploidy status of the embryos and you know that it's an euploid embryo, whether it is day 5 embryo or a day 6 embryo, there is no difference in the implantation rate and the clinical pregnancy rate of these euploid transfers, whether they were biopsied and frozen on day 5 or day 6. So then, are we suggesting that any aneuploidy is the only reason for poor implantation potential in delayed blastulation? So now this is another study which is more recent, 2018 by Mohammad Irani and group, which looked at the blastocyst development rate, whether it influences the implantation and live birth rate. when you have similarly graded euploid embryos. And what does the study suggest? The live birth rate of euploid transfers between day 5 and day 6 was significantly higher on day 5 as compared to day 6. Now, when a subgrouping of these embryos was done, and when they looked at the analysis of grade-wise euploidy rate and their implantation rate, it suggested that even the implantation rate was higher for day 5 embryos, so similarly graded day 5 embryos as compared to day 6 embryos, and so was the implantation rate. So then day 5 euploid transfer does seem to have higher implantation rate and live birth rate, even in similarly graded day 6 transfers as per this study. So in addition to aneuploidy assessment, what they suggest is that the speed of development could also be crucial, and this is something that we need to consider when we do a euploid transfer. So apart from aneuploidy, the other factors that could also be compromising the developmental potential is the metabolic profiling of the status of the embryo, the epigenetic alterations that is known to happen with extended culture. Now, studies do suggest that there is a difference in transcripts of in vivo and in vitro cultured blastocysts. Studies in bovine blastocysts suggest that the RNA expression patterns are different in slower growing blastocysts. And what we as embryologists need to know is that these factors could be influenced by the culture conditions. Hence, again, re-emphasizing that culture conditions are extremely crucial to the implantation potential of the embryos, more specifically the blastocysts. Now, coming to the day 7 blastocysts, and I thought this was something we needed to bring into discussion because of late there are few centers who also extend their culture beyond day 6 to day 7, especially those centers which are into embryo pre-implantation embryo screening. So now most of us would call off the culture on day 6. And why do we do so? If we look at the history, in 2011, the Alpha and ASHRAE special interest group in embryology suggested that day 7 and day 8 blastocysts have a very poor prognosis. In fact, the 2013 ASRM practice committee guidelines do not specify only day 5 and day 6 transfers. They do not even mention day 7 transfers. And hence most of us do not extend routinely, do not extend the culture to day 7. And now this is some interesting data that we need to look at concerning day 7 blastocysts. And of course, this is not a part of the meta-analysis that we looked into. So no doubt, day 7 embryos are much slower than day 6 embryos. But there are studies now that are coming up which suggest that even day 7 embryos, blastocysts can reach good morphology. They can form euploid embryos and they can result in a healthy live birth. So what is the status of day 7 embryos? What is the incidence of probably finding a good embryo or being able to grow an embryo to day 7? And hence I included this mini review, which is again recent by Elizabeth Harmon, which this includes again 10 studies. These are all obviously frozen embryo transfers, which look at day 7 embryo transfers and how they perform. We do know that the limitation here is that there is very limited evidence whatsoever on fresh transfers as far as day 7 embryos are concerned. So according to this mini review, the utilization rate, and here by utilization rate, we mean that how many % of these embryos actually get frozen. If we look at the incidence, barely 5% of the embryos would reach a good morphology on day 7, wherein we could freeze them, as compared to 65% on day 5 or 30% on day 6. But we do understand that the utilization rate is very dependent on the morphological grading, which is again very subjective. So what is the implantation rate if we happen to transfer these embryos on day 7? And again, these are frozen embryo transfers. it is between 17 to 56%. The clinical pregnancy rate on a day 7 blastocyst would be around 20 to 56%. The live birth rate is around 11 to 42%. But I must say that the number here are very low. We are looking at only 58 live birth rates. So how do these embryos perform when the embryo biopsy is performed on them? Again, like we said earlier, 5% would reach a utilization rate. Between 2 to 6% of these embryos would reach a stage on day 7 where we could consider them for biopsy. On an average, 25 to 49% of this could still be euploid. So no doubt that day 5 embryos or day 5 blastocysts do have a higher euploid rates, but some studies have even suggested, like the study by Whitney et al. In 2016, that the euploidy rate could be similar for day 6 and day 7 blastocysts. However, what is most important here is that this mini review suggests that the miscarriage rate when we do a day 7 transfer could be 10-fold higher, is around 22% as compared to day 5 embryos, which would be barely 2%. So definitely this is a matter of concern when we consider day 7 embryos. Regarding perinatal outcomes, only one study consisting of 8 births which said that the perinatal outcomes as regards the gestational weight, the preterm delivery rate, and the birth weight were not significantly different as compared to day 5 and day 6 transfers. So now, what is the applicability of day 7 transfers? We do understand that they likely have a reduced potential for pregnancy and live birth rate as compared to day 5 or even day 6 transfers. So definitely we cannot at this stage suggest a universal applicability of day 7 blastocyst, but there are special scenarios where we could consider a day 7 blastocyst, where patients have innately slower growing embryos, where on an average you're seeing early blastulation, for example, on day 6, right? When a patient has very low number of blastocysts or no blastocysts at all on day 5 or day 6, and then you would wish to extend the culture another day to day 7, where, for example, on day 6, you just see an early blastulation and you want, and then if you extend the culture to day 7, either you could see them well expanded or probably degenerated. For embryo biopsies, yes, on day 6, if the embryo is not ready for biopsy, we do end up culturing it for another day. Or during biopsy or just before biopsy, if the embryo collapses, then you wait for another few more hours. Some would wait for the next day on day 7 to attempt a biopsy on these embryos. So these are very special scenarios probably where you could consider day 7 embryos. What could be a better strategy is to rank the embryos, giving day 5 embryos the first preference and day 7 being down the ladder. So this is something that has already been suggested by Su et al. In 2016, even in euploid embryos. So sometimes we do think that, okay, if it's euploid, whether I transfer a day 5 or a day 6 or a day 7, the outcomes may not differ. But when you have an option between a euploid day 5, day 6 and day 7, it would be a better option to rank them, give preference to day 5 euploid transfers over day 6, and day 7 could be the last in the ranking. So day 7 is clinically a significant group, especially in patients who have extremely low number of blastocysts, which challenges the routine discarding of embryos on day 6. So the independent effect of day 7 cryopreservation definitely warrants further research. Time-lapse studies could add a lot of information. Standalone day 7 morphokinetic studies are not there, are not many, I guess. Definitely before considering an extended culture to day 7, a cost analysis is required to support its applicability for cryopreservation. So to conclude, yes, delayed blastulation does impact the implantation potential and the overall clinical outcomes. Day blastocysts should be considered in the absence of good quality day 5 blastocysts. Day 5 embryos should be considered for transfer even when you have similarly graded day 6 blastocysts. In cases of delayed blastulation, a frozen embryo transfer should give better outcome as compared to a fresh transfer. So it's always better to freeze these embryos and then do a frozen transfer. Day 7 embryos is something that we need to consider in special scenarios, as we have discussed earlier. So with that, I conclude this presentation and over to Dr. Gaurav.
Thank you, Dr. Varsha, for exhaustive presentation on day 5 and day 6 embryos. You'd like to unshare your screen now so that we can see a bigger thumbnail of yours. Yeah. All right. So we have a number of questions, and I'll probably also just put in my bit about what we understood from this whole paper. That obviously we are all now culturing embryos to blastocyst stage. A lot of us are. And we also understand that not all blastocysts, they appear on day 5. So a lot of them, there's a lot of variation in the growth dynamics of blastocysts. And a lot of things will probably affect the growth dynamics of blastocysts, like probably culture media, the culture systems, the environment. That's still unknown as to what are the things which will probably slow down an embryo or hasten its growth. But so this is a very important research question that about the clinical outcomes linked with transfer of day 6 and day 5 embryos. And from your talk, it is clear that in terms of all clinical outcomes, day 5 fares better than day 6, whether it is fresh or frozen. So I read an article in 2018 in the Human Reproduction, which further bifurcated day 6 embryos. And it was very interesting. And let me just quickly give the results of that study. So these guys, they classified day 6 embryos into 2 types. One where the same embryos on day 5 were just morulas. So they were at the morula stage on day 5. So obviously you waited for another day and saw whether they make good expanded full blastocysts or not. And then these embryos were transferred either in fresh cycles or in frozen cycles. And another group of embryos which produced full blastocysts or expanded blastocysts on day 6, they were actually not morulas, but they were more advanced than morulas, and they were at the early blastocyst stage. So interestingly, what this paper found was that if such day 6 embryos were transferred in fresh cycles, which had already been at the early blastocyst stage in that cycle, then doing a fresh cycle on day 6 actually yielded similar pregnancy rates as transferring day 5 embryos. However, when they transferred those day 6 embryos, which were morulas on day 5, there the live birth, there the fresh transfer clinical pregnancy rates were very poor. So when they transferred embryos that were morulas on day 5 and then they became full blastocysts on day 6, they transferred those, the clinical pregnancy rate in the fresh ET was 5%, right? And vis-a-vis, when these same embryos which were morulas on day 5 and they became full good blastocysts on day 6, when they froze them and they chose to transfer them in a FET, the pregnancy rate became 30%, which is what we understand, which is normal. But the interesting bit comes in when they looked at blastocysts which were actually early blastocysts on day 5, not morulas. So probably they were advanced in their growth by about 12 to 20 hours. So here they said that even if they went ahead and transferred those embryos in the same cycle without freezing them, like we would normally tend to. We know that an embryo is a day 6 embryo, so obviously we know by all the results you showed that the chances of pregnancy will be very low as compared to day 5. So let's freeze it and transfer it in the subsequent FET. So they transferred, and in the fresh ET, they got a clinical pregnancy rate of 31%. And whereas if the same embryo would have been frozen and then transferred in a subsequent FET, the pregnancy rate was again 30.4%. So this was interesting. So probably they just gave a clue that some day 6 embryos can probably still be transferred based on their speed of growth. And we understand by what you said, by the aneuploidy linkage that you explained about that, when an embryo grows slowly, it's probably aneuploid, right? It's probably aneuploid. So here, if an embryo has already reached an early blastocyst stage, then maybe I'm guessing that it's not aneuploid, and it's the culture conditions and the variability in the incubators which is causing that variation in growth. So this was interesting, but this is good stuff that we know that. Unfortunately, can I ask you one thing, Dr. Varsha? That in this meta-analysis, I think you mentioned some 23 studies were included.
Yes, in the clinical pregnancy rate. Out of the 23 were included in the clinical pregnancy.
Were there any RCTs in this in these papers?
Yes. So of the total 29 studies that were included, they were prospective studies, they were RCTs. So that's why I categorize them as these were all observational studies. But coming to your point of having a compacted embryo on day 5 and early cavitating embryo on day 5 and probably early blastocyst, and taking them to day 6. I think some information, though we've not included time lapse in this discussion, which was, I think time lapse was discussed in the last journal club. I think the time interval for good blastocyst, viable blastocyst, is between 112 and 120 hours, if I'm not mistaken. And if we're looking at day 6 embryos, it is like 160 plus hours, which is a huge deviation from what even time lapse suggests morphokinetically would be a normal embryo. Another study, I think it's in 2013 by Alstrom and group, which looked at transferring embryos. I think the embryos which showed a delayed blastulation, and embryos, say if you have a compacting on day 5 and or early cavitating on day 5 and an expanded on day 6, and these were frozen and then offered for a frozen embryo transfer. The one which had advanced development, which was an expanded though on day 6, performed better.
Yeah, exactly.
In the frozen cycle. So yes, again that, and I don't remember the numbers, but that's again a good and a huge study, including studies which correlate morphokinetics to a classification model by Campbell, also suggests that timelines are important even if we compare morphokinetics with ploidy status. So again, coming back to the same, secondly, I think the study that you mentioned, probably you said it is pregnancy rate, and so we're not very sure about the miscarriage rate. That is something
they also mentioned the live birth rate. They
Okay.
also mentioned the live birth rate. Similar.
Right.
I did not read out the live birth rate, but that takes into account miscarriage rate also.
Miscarriage rate, yes. So I think we're all, we can conclude saying that we do prefer day 5 transfers.
Definitely.
Definitely. Considering day 5 up the ladder as compared to day 6, day 7, even in similarly graded.
There are a lot of questions now. So should I'll just go through the list.
Has to tell us.
We have about 20 minutes. So, so one of the questions out of the list was that are there any RCTs, comparing day 5 and day 6?
Yes.
So that we just answered. And unfortunately, there's also a lot of selection bias which comes into transferring a day 6. So any patient who has a day 5 and a day 6 embryo will always tend to first transfer the day 5. And so there are so many day 6 embryos which never see the light of day. So if there was a proper system of randomizing and transferring embryos, then probably, we'd find out.
And in this kind of a study, I think we need to understand if we're considering the same patient to level the ground and considering a day 5 and a day 6 transfer, definitely we're looking at probably one fresh transfer and one frozen transfer or frozen transfers. So it can never be a leveling ground where we say, we've done a day 5 and a day 6 in a fresh transfer and we've seen the outcome in the same patient. So this is a huge limiting factor in this particular kind of a study.
Okay, so let's quickly look at some of the questions. So Dr. Chandan has posed a question to you saying that if day 5 embryos do not expand completely on day 5, and you suggest that they should be grown till day 6, so how does endometrium preparation play a role? Since because of the endometrial and the embryo, the synchrony between the embryo and the endometrial. So they want to know about the endometrial preparation for a day 6 embryo.
Okay, so when you have an early blastocyst on day 5, you extend the culture to day 6. Then the best way forward would be to freeze the embryo on day 6 and program her for a frozen embryo transfer. Now, in a frozen embryo transfer, you're going to treat the endometrium as a day 5 endometrium, day 5 blastocyst, and prepare the endometrium accordingly, not considering, because we consider the number of days of progesterone administration. So you should never consider it as a day 6 embryo and extend the progesterone for another day. Consider it as a day 5 blastocyst for the purpose of frozen embryo transfer, though you would have frozen it on day 6. This is the way we're going to, synchronize the embryo and the endometrium and, allow the implantation window to be right at the time you're going to do a transfer.
Would you advise the same for day 7 embryos also?
I don't have any evidence in the literature. I'm not aware about day 7 since these are very limited studies, but I would presume because delayed blastulation, the window is only going to, close down much more. So I think it becomes much more applicable in day 7 as compared to day 6.
So the embryo is not aneuploid. That's the only thing that we'll hope for. Because there'll be very, very high chances that the embryo is aneuploid.
Yes, and we do know that the miscarriage rates, though day 7 embryos may implant, but they have a
very high,
huge higher implantation, miscarriage rate as compared to
someone anonymous who's asked that would you find the embryo to be hatching on day 7? Well, yeah, I think it would in all probability. Embryos are mostly hatching on day 6 itself.
Yes. So by day 6 evening or day 7, you would find it hatching. So yes, I wouldn't be surprised.
Then Dr. Nirmala TS has asked the same question again about whether you would give 5 days of progesterone, whether that would be sufficient for a day 5 or day 6 or day 7 transfer, or would you consider adding an extra day? Well, we've just answered that question. And okay, so there is this question from Mizanur Rehman from Dhaka, Bangladesh, and he says that our day 5 blastocysts with grade 4 AA, and we have transferred them in about 12 patients, but we got no pregnancy. But it is unclear whether they've transferred them in frozen cycles or fresh cycles. So yes, this is multifactorial.
Yes, yes. And for day 5, a 4AA is a good blastocyst. Yes. Even if you transfer in a fresh cycle, you expect good outcomes. So yes, there's a huge lot of troubleshooting involved here.
Yes, as far as embryos are concerned, if you're getting 4 AAs on day 5, then you're okay over there. But you have to check your other protocols of transfer. Okay, so there is one question where they say, when do they, so people are very fascinated by the day 7 blastocysts that you've mentioned. So there are a lot of questions on day 7.
Let us make it very clear, we cannot use it universally. These are
Uh,
only special scenarios.
I think we do well if we first successfully culture them to day 6 and stop thinking of day 7. But there's a question where Mr. Aman Mishra has asked that when do you change media if you are culturing till day 7 using single step media? So, please.
Yeah, so single step media, there are two protocols. You could either change the media midway day 3 or day 4, or you could continue culturing in the same media for day 5, day 6, day 7. Now, the information that we've obtained again from time-lapse studies is that embryos cultured in the same media over the 5 days or 6 days do not seem to, impact the embryo development grossly. So I would say, one, there is very limited knowledge as far as day 7 embryo extended culture is concerned. It all depends on your internal policies. There are cost implications. You do know that the day 7 embryos are not the best. Only in special conditions or special scenarios you're going to consider day 7. So these are something these individual labs need to take a call, whether you change it on day 5, you continue with the same on day 6, day 7. As far as literature is concerned, I'm not aware of any paper that has looked into whether there needs to be changed if you're extending it to day 7.
They are just anecdotes which are there in literature. The next question, again, someone who's anonymous, not given their name, have asked that in RIF, do you advise PGS? And if so, should it be done on day 5 or day 6 blastocyst?
Okay, so recurrent implantation failure is completely a different category where you need to look at multiple factors which could be causing the failure of implantation. PGS or now what we call it as PGTA is one of the ways of addressing recurrent implantation failure. Now, if you're doing an embryo biopsy, whether it is for RIF or for any other indication, what we did address in the presentation earlier is that if you have a blastocyst which reaches the stage to be biopsied on day 5, then there is no reason for you to extend it to day 6. So again, it depends, your ability to do the biopsy also depends on the growth of the embryo. If you have an early cavitating, early blastocyst there, it's extremely difficult to do a biopsy on that embryo. So that is what embryologists are going to tell you. So you do need to wait till the embryo reaches the particular stage. There are some who would do a biopsy in a fully expanded, while there are some embryologists who wait for some amount of hatching to happen. This is their individual skills. So it needs to reach the minimum level to do a biopsy. So it is not dependent on whether it's day 5 or day 6, unfortunately. That's why studies which looked at euploid transfers, comparing day 5, day 6, which we had studies which some of them suggested as long as they're euploid, the implantation potential is the same. Then we've seen some studies which say that day 5 fare better euploid embryos as compared to day 6. So it depends on whether the embryo has reached the stage for the embryologist to conduct a biopsy. If not, then you have to wait for day 5, so day 6.
As a rule in our laboratory, we wait for the embryo to be completely expanded or early hatching. We don't go in before that. So as a result, more than 50% of our biopsies are done on day 6 and not day 5. Because day 5, the cell numbers are also on the lower side and the embryo may not have fully expanded. So biopsy is tricky with a low cell number.
Yes. So
okay.
So level is it needs to reach full expansion.
Okay. So there is another question by another anonymous attendee, where they've asked that could you please explain if a single step culture medium or a sequential culture medium would give better results in terms of blastocyst culture. Which media is better?
Okay, so this is a question that is posed, I think, for in every session and every conference. The fact is that we don't have a straightforward answer which says this is better than that. So how do laboratories opt to go for either this or that? One, it is your individual preference. The advantage that a single step media gives you is that the cost implications. Second, you don't have to change the media on day 3 or revive the media, especially today when more and more clinics are opting for blastocyst transfer. So basically it's convenience. As far as outcomes are concerned, I don't think there is any evidence to suggest that this performs better than that.
Okay. Thank you. Thank you, Dr. Varsha, for that. So we don't yet have evidence about which culture system to use. The next question is concerning biopsy by Raja Rajan K. And he has asked that, do you know that even collapsed embryos can be biopsied well without affecting the ICM? So there are a lot of questions on biopsy, surprisingly.
Okay, so I think here Dr. Gaurav also does embryo biopsies, and I too do embryo biopsies in our clinics. And from personal experience, what I would suggest is that if I have a collapsed blastocyst, one, it is very difficult to identify where the inner cell mass is. So the whole aim of the biopsy is to not touch the inner cell mass. So when you have a collapsed blastocyst, because collapse and expansion of a blastocyst is considered a physiological phenomenon. So you just wait for a few hours, 2 to 4 hours, and you will see the blastocyst expanding unless it is non-viable. So from my end, I think it would be worthwhile waiting for those few hours to allow time for the blastocyst to expand, show us a clear demarcation between where the ICM is and where the T cells are, and then proceed with the biopsy. What Gaurav stated.
Yeah, sure. That's true. You need to be safe and not take chances. Then there is one question which has been addressed to me where they say that what are the culture conditions that may affect growth dynamics of blastocysts? Well, it's your culture system, and it could be your medium or your environment or the air quality or the VOC levels or the toxicity, temperature, heat,
everything.
It could be anything which is causing any form of embryonic stress, which is forming any form of embryonic stress, and that will be directly visible in the growth pattern of the embryo. There's a comment which Dr. Geeta Goswami from Delhi has made, where she has actually made a valid point here that in 2020, Spangmose has questioned that whether blastocyst transfer should be considered as a gold standard because of the risks attached with extended culture, he found in his study. So here we are talking about day 6 and day 7 transfers now, in this
yes,
age of...
I'm extremely happy Dr. Goswami got this point on board, because this was something...
She said, is it justified?
So I think this is the article that she's stating is the one that has appeared in the recent reproduction focus, right? Where, yes, the perinatal outcomes, whether it's the gestational weight or the birth weight or the preterm rate, delivery rate of blastocyst transfers. And this study looks at the fresh transfers. The same group looked at frozen transfers in their earlier papers, and there are huge concerns. Definitely, I do not disagree. So a point of caution, whether it is blastocyst transfer or any form of extended culture, in that I also would bring in vitro maturation, where you're extending the culture of those oocytes for another 24 to 48 hours. We do know of papers that have come out stating that there can be epigenetic alterations. What the overall impact of these is unknown, but it does raise a lot of red flags. So I do agree with Dr. Goswami that we should have, and every clinic, I would suggest, I do know of some clinics who would have a all blastocyst transfer policy. I would be more conservative in saying that, you should be very selective of where you offer blastocyst transfer in a patient. And I think that is what ASRM guidelines also suggest regarding the blastocyst transfer. The committee opinion also suggests that you need to segregate the patients into good prognosis. A 28-year-old lady, a young lady who's going through ICSI only because of a severe male factor or azoospermia being the cause of her infertility, definitely is a good prognosis patient. So you could select 2 good embryos on day 3 and give her a transfer rather than extend it to day 5, because she's the one who's in good prognosis. It will have a high chance of conceiving even with a cleavage stage transfer. So I think we need to be selective on whom we offer the blastocyst transfer. With these latest evidence coming out stating the concerns both in fresh and frozen embryo transfer of the perinatal outcomes, I think we need to have policies in place where we select individuals specifically for blastocyst transfer.
And when we mention day 7 transfers or day 6 transfers, these are for those patients where they have no other option, and they have no other embryos, and this is their only chance. So in a very minuscule population, maybe we'll find a live birth in a day 7 blastocyst. And that's why of what we were talking about, that we can never probably randomize day 6 embryos before day 5 embryos, because this threat of epigenetic contribution will always be there. So we'll always choose day 5 before day 6 and day 6 before day 7. So we'll never get to test out that hypothesis of whether, what happens if we do actual randomization. Okay, and then we have one of the attendees has asked that, Madam, we have done day 6 transfer and the patient was prepared with 6 days of progesterone. 2 patients were given 6 days of progesterone. One was positive and the other was negative. So this is just a matter of chance. So right. You increase the chances of the window closing by giving 6 days of progesterone. So, and okay, Dr. Praveen Upadhyay is asking, if blastocyst forms on day 4, what will you do? What will be preferred to, what will be the endometrium? I don't think that's possible.
Okay. I think even if you see a blastocyst on day 4 evening, you might see early cavitation. So I wouldn't really categorize it into a blastocyst. We rarely, I don't remember seeing, even an early blastocyst on day 4. Definitely not in the morning. So like I said, if you're looking at 118 hours by morphokinetics, we're looking at 118 to 120 hours, which is like day 5 morning probably. So day 4, these would be just cavitating embryos where, again, if you have to grade them, you have to wait for a little more of expansion to happen, so you can have a clear demarcation.
I'll complete the question. I'll complete the question. So we understand that it's highly unlikely that we see a blastocyst on day 4. But even say if hypothetically we were to see a blastocyst on day 4, and rather I'd be very worried if I see a blastocyst on day 4, that this is an abnormal speed of development. So that would ring a bell. But say if hypothetically we had a blastocyst on day 4, so they want to know that then if the embryo had to be transferred, probably in a FET, then how many days would we give progesterone, for 4 days or 5 days? So the message is, when you see a blastocyst, irrespective of whether it was formed on day 4 or 5 or 6 or 7, we see it as a blastocyst per se. And then in a FET, we want to transfer it at 5 days of progesterone. We don't want to tinker with that. So does this study reveal the method of vitrification? No. Well, there are also some papers which have done slow freezing.
The majority of them have been with vitrification. So I think that is one of the drawbacks or limitations of the other meta-analysis of Sunkara that we looked into, which had more of slow freezing. Today, we know that all of us have moved towards vitrification.
Yes. So we'll end, Varsha, with a final question by our President of Academy of Clinical Embryologists, Dr. Swami. And he's asking that in day 5 or in day 6, how many blastocysts should be transferred? Should it be strictly single embryo transfer? And if we transfer more than one, then does it affect the outcome?
Okay, so I think the whole concept of blastocyst transfer is designed to have a single embryo transfer. Yes. So I would say it should ideally be single embryo transfer. Second, we do know that the implantation potential is very high when we compare blastocysts to cleavage stage embryos. That's why when we do a cleavage stage embryo transfer, we transfer 2 or 3 embryos. Very rarely do we transfer a single embryo at the cleavage stage. So I would still say a single blastocyst transfer, because twin pregnancy, I don't think we must look at multiple pregnancy as an achievement. It is not a success. In fact, it is a failure of the system, because multiple pregnancy rate, any obstetrician is going to tell you, is not something that they would want. There are obstetric complications, perinatal complications associated with it. So yes, it ideally should be a single embryo transfer.
I completely agree with you that then the whole purpose of extended culture is lost. Because if in the first place, if you wanted to transfer 2 embryos, then why wait till day 5 and day 6? Then you might as well transfer that on day 3. The very reason that we waited till day 5 or day 6 was to identify the best embryo out of the lot. And knowing that one embryo will probably equivalent in its implantation rate to 2 or 3 day 3 embryos. So there is absolutely no question of transferring 2 embryos at the blastocyst stage, because it also leads to a very high multiple pregnancy rate, probably much higher than if transferring at day 3. So we are now finished our allotted 1 hour, Dr. Varsha. So thank you very much for this very lucid discussion about this very important topic, which all of us face in our laboratories on a daily life. And I'm sure that all the clinicians as well as embryologists would have gained something after listening to a detailed analysis of this very, very important meta-analysis about day 5 and day 6 embryos. So thank you very much.
Thank you so much.
Thank you. Thank you, Dr. Varsha and Dr. Gaurav. I think it was a fantastic journal club with all the details coming in, and in the end collating both of your views while answering. I know there are still a lot of questions that were there in the window, and we can't take it because of the time limitation. But thank you very much, and thanks everyone for joining in.